everyone, and welcome to the Cardiovascular and Lymphatic Systems. I am creating these videos to hopefully help you gain a better understanding of what you are reading and the material that you are learning. So let's get started. The cardiovascular system is made up of three main components: blood vessels, and the heart. The heart is conjoined of two pumps moving blood through two separate circulatory systems. The heart has four chambers: the right atrium, the left atrium, the right ventricle, and the left ventricle. The right heart pumps blood through the lungs, termed the pulmonary circulation. The left side of the heart sends blood through the systemic circulation, which supplies all of the body except for the lungs. So as you can see here, the right heart receives deoxygenated blood from the systemic circulation. The right heart pumps it to the lungs, gets oxygenated, which then goes into the left heart. The left heart pumps the oxygenated blood to the systemic circulation. Okay, so that's the nitty-gritty of the cardiovascular system. So let's move on to the assessment of the cardiovascular function. So main thing is a thorough patient history and determining their risk factors. Some of the common tests that are used to evaluate and diagnose cardiac or coronary artery disease include chest x-ray, ECG, echocardiography, stress testing, CT scan, and MRIs. Chest x-ray allows for the examination of the size and contour of the heart and related structures. 12-lead ECGs give information about heart rate and rhythm. Serial 12-lead ECGs primarily are important in establishing the presence of myocardial ischemia and infarction or conduction defects in dysrhythmias. Echocardiography is the most effective and widely used non-invasive modality for evaluating the structures of the heart. Stress testing elicits signs and symptoms of heart disease and coronary artery disease that may not appear at rest. It is most accurate with men greater than 50 with typical angina. CT and MRI are used to evaluate cardiac anatomy and physiology. A calcium score can be obtained using the CT, which looks for calcifications in the coronary arteries, whereas a coronary CTA can only look at the vessels. Cardiovascular disease is the leading cause of death in both the United States and worldwide. Disorders of the veins, arteries, and heart wall comprise the scope of the cardiovascular disease. Varicose veins refers to a condition in which the venous blood has pooled, producing distortion in the veins. Varicose veins can progress to chronic venous insufficiency, which can cause lower extremity edema, pain, skin changes, and necrosis. Hypertension is one of the main diseases of the arteries. It is defined as consistent elevation of systemic arterial blood pressure greater than 130. Now, before diagnosing someone with hypertension, you need at least 3 elevated blood pressures on 3 separate occasions, some of them even not in the office because they can have white coat syndrome or hypertension in a clinical environment. So give the patient a log, have them take their blood pressure at home. You should also have a good understanding of what the RAS system is, so please review that. An aneurysm is a localized dilation or outpoaching of a vessel wall or cardiac chamber. Aneurysms most commonly occur in the thoracic or abdominal aorta. Signs and symptoms depend on where the aneurysm is located. If in the heart, dysrhythmias, heart failure, or clots to the brain or the organs can occur. Aortic aneurysms are typically asymptomatic until they rupture. Symptoms include dysphagia, dyspnea, or pulsatile back pain. Fusiform are true aneurysms caused by weakening of the blood vessel wall. False or saccular aneurysms involve a break in the vessel wall, typically by trauma. Raynaud's disease is a vasospastic disorder. It is associated with a number of different disorders. The attacks are characterized by the digits going white, cold, and painful, and can appear cyanotic, followed by the capillaries becoming engorged with oxygenated blood and becoming bright red. Prolonged attacks can lead to ulcerations and gangrene. Atherosclerosis starts with damaged endothelium, most commonly from toxins of smoking or hypertension. The damaged endothelium forms fatty streaks and lipid core formation. Then a fibrous plaque forms, which can then lead to a complicated lesion. These plaques can form anywhere. If in the limbs, it is classified as peripheral artery disease. PAD. If in the heart, coronary artery disease, CAD. In gradually forming PAD, the increasing obstruction to blood flow can cause pain with ambulation called intermittent claudication. In gradually progressive CAD, transient myocardial ischemia syndrome can occur. CAD and associated myocardial infarction is the #1 cause of death in both men and women in the United States. In individuals at risk, a lipid profile should be done, which requires a 12-hour fast. Unstable angina is the result of reversible myocardial ischemia and is a warning of impending infarction. Myocardial infarction results when prolonged ischemia causes irreversible damage to the heart muscle. Broken heart syndrome, now called Takotsubo's cardiomyopathy, is a reversible cardiomyopathy brought on by extreme mental stress. Patients may present with ST elevation on the ECG, chest pain, dyspnea, and elevated troponins and BNP. When the patient is taken to the cath lab, the images look like an octopus caught in a trap, hence the name Takotsubo's cardiomyopathy. Pericarditis is inflammation of the pericardium. Pericardial effusion is the accumulation of fluid in the pericardial cavity and can occur in all forms of pericarditis. On imaging, you will see the water bottle signal, which looks like a leather bag filled with water. Pericardial effusion may create sufficient pressure to cause cardiac compression, which is a serious condition known as tamponade. Individuals with cardiac tamponade most often present with dyspnea, tachycardia, jugular venous distension, cardiomegaly, and pulsus paradoxus. Cardiomyopathies are a diverse group of diseases that affect the myocardium and include dilated cardiomyopathy, hypertrophic cardiomyopathy, and restrictive cardiomyopathy. Dilated cardiomyopathies are characterized by impaired systolic function leading to increased intracardiac volume, ventricular dilation, and heart failure with reduced ejection fraction. Arrhythmias are also common. Symptoms include dyspnea, fatigue, pedal edema, displaced apical pulse, S3 gallop, JVD, and pulmonary congestion. Severe cases require a heart transplant. Hypertrophic cardiomyopathy refers to two major categories of thickening of the myocardium: hypertrophic obstructive cardiomyopathy and hypertensive or valvular hypertrophic cardiomyopathy. It is the most common inherited heart defect associated with left ventricular hypertrophy. It is characterized by thickening of the septal wall. Hypertensive or valvular hypertrophic cardiomyopathy occurs because of increased resistance to ventricular ejection and is commonly seen in hypertensive or valvular stenosis, usually aortic. Restrictive cardiomyopathy is characterized by restrictive filling and reduced diastolic volume of either or both ventricles with normal or near normal systolic function and wall thickness. The myocardium becomes rigid and non-compliant, impeding ventricular filling and raising filling pressures during diastole. Disorders of the endocardium, the innermost lining of the heart wall, damage the heart valves, which are made up of endocardial tissue. In valvular stenosis, the valve orifice is constricted and narrowed, impeding the forward flow of blood and increasing the workload of the cardiac chamber proximal to the diseased valve. In valvular regurgitation, also called insufficiency or incompetence, the valve leaflets or cusps fail to shut completely, permitting blood flow to continue even when the valve is supposed to be closed. Aortic stenosis is the most common valvular abnormality. The three most common causes are calcified degeneration related to aging, congenital bicuspid valve, and inflammatory damage caused by rheumatic heart disease. Mitral stenosis impairs the flow of blood from the left atrium to the left ventricle. Mitral stenosis is the most common form of rheumatic heart disease. Aortic regurgitation results from an inability of the aortic valve leaflets to close properly during ventricular diastole, resulting from abnormalities of the leaflets or the aortic root, or both. Mitral regurgitation permits backflow of blood from the left ventricle into the left atrium during ventricular systole, giving rise to a loud pansolic murmur heard best at the apex that radiates into the neck and axilla. Tricuspid regurgitation is more common than tricuspid stenosis and usually is associated with dilation and failure of the right ventricle secondary to pulmonary hypertension. Mitral valve prolapse syndrome is a condition in which the anterior and posterior cusps of the mitral valve billow upwards, prolapse, into the atrium during systole. Now some mnemonics to help you remember systolic and diastolic heart murmurs. For systolic heart murmurs, Mr. Pass, which is mitral regurgitation and aortic stenosis, and the most valuable player reward, MVP, mitral valve prolapse. As for diastolic heart murmurs, Mrs. Ard, mitral stenosis, aortic regurgitation. The D is diastolic. So to remember the symptoms of aortic stenosis, SAD mnemonic, syncope, angina, dyspnea. Rheumatic fever is a systemic inflammatory disease caused by group A beta hemolytic streptococci, occurring in children ages 5 to 15, and if left untreated, can lead to rheumatic heart disease. The major clinical manifestations of acute rheumatic fever are carditis, acute migratory polyarthritis, subcutaneous nodules, chorea, and erythema marginatum. Please review the Jones criteria, which is the diagnostic criteria for rheumatic fever. Heart failure is when the heart is unable to generate an adequate cardiac output, resulting in inadequate perfusion to the tissues, or an increased diastolic filling pressure of the left ventricle, or when both consequently occur. Left heart failure, also known as congestive heart failure, is categorized as systolic, reduced ejection fraction, or diastolic, reserved ejection fraction. When the heart can't pump well enough, blood backs up into the other parts of the body, including the lungs, liver, GI tract, and the legs. There is also a decrease in forward perfusion, which activates the renin-angiotensin-aldosterone system, which worsens CHF due to fluid retention. The clinical manifestations are the result of pulmonary vascular congestion and include dyspnea, orthopnea, fatigue, edema, decreased urine output, and frothy pink sputum. Right-sided heart failure symptoms include dyspnea, since the right heart is unable to pump blood into the lungs to get oxygenated, JVD, since the jugular veins cannot empty their blood into the right atrium, pitting edema, due to the fluid overload and increased hydrostatic pressure, ascites, which is due to fluid accumulation in the peritoneal cavity, and a nutmeg liver, which is due to chronic passive congestion of the liver, and as you can see, looks like nutmeg. Okay, so now we're moving on to alterations of cardiovascular function in children. Separation first begins when collections of mesangial cells cause the endocardial lining of the heart to bulge into the internal lumen. These changes are known as the endocardial cushions and are instrumental in closing the lower portion of the atrial septum, dividing the atrioventricular canals into the right and left AV orifices, and forming the upper portion of the intraventricular septum. In order to deliver maximally oxygenated blood to the developing brain, fetal circulation differs from adult pattern by the presence of alternate pathways known as fetal shunts. At birth, a series of circulatory changes can occur that affect blood flow, vascular resistance, and oxygen tension. The most important changes that take place in the circulation is the shift of gas exchange from the placenta to the lungs. In addition, alterations in pressure and volume of blood flowing through the heart chambers functionally close the ductus arteriosus, ductus venosus, and foramen ovale. Congenital heart disease is the leading cause of death, excluding prematurity during the first year of life. Heart failure is classified as an acquired condition. Heart failure occurs when the heart is unable to maintain sufficient cardiac output to meet the metabolic demands of the body. The pathophysiological mechanisms of heart failure in infants and children are very similar to those in adults. Cardiac lesions that increase pulmonary blood flow include defects that involve septal abnormalities or communications between the great vessels. These allow the shunting of blood from high pressure left side to the lower pressure right side. Children with significant left to right shunts left untreated are at risk for development of irreversible pulmonary hypertension. These defects include patent ductus arteriosus, atrial septal defect, ventricular septal defect, and atrioventricular canal defect. Defects decreasing pulmonary blood flow involve obstruction to pulmonary blood flow and septal communications. Because of the RV outflow tract obstruction, right-sided pressures exceed left-sided pressures, resulting in right to left shunting. Children with these defects have hypoxia and cyanosis. The defects include tetralogy of Fallot and tricuspid atresia. Obstructive defects are conditions in which anatomic stenosis, narrowing, in either the right or the left outflow tract obstructs blood flow and results in a pressure load on the affected ventricle. Symptoms associated with the defect depend on the site and severity of the stenosis. Defects include coarctation of the aorta, aortic stenosis, or pulmonary stenosis. Many complex defects are classified as mixing defects because of their dependence on the mixing of pulmonary and systemic circulation for survival during the postnatal period. Clinically, each defect has varying degrees of cyanosis and heart failure depending on the various components of the lesion. The defects include transposition of the great arteries, total anomalous pulmonary venous connection, truncus arteriosus, and hypoplastic left heart syndrome. Switching gears, we now go to Kawasaki disease, which is an acute, self-limiting systemic vasculitis that may have cardiac sequelae. Kawasaki disease is primarily a condition of young children, and most of the cases are seen in children younger than 5 years of age, with the incidence peaking in the toddler age range. Symptoms include a high fever of 103 to 105, greater than 5 days, sometimes upwards of 2 weeks, conjunctivitis, cracked lips and a strawberry tongue, sore throat and swollen neck glands, red feet and hands, peeling skin, joint pain, and a rash on the trunk and on the limbs. Stage 1, days 1 to 12, small capillaries, arterioles, and venules become inflamed, as does the heart itself. In stage 2, days 13 to 25, inflammation spreads to larger vessels and aneurysms of the coronary arteries develop. Stage 3, days 26 to 40, medium-sized arteries begin the granulation process, causing coronary artery thickening. Inflammation resolves in the microcirculation, and there is a risk of thrombus formation. Finally, in stage 4, days 41 and beyond, vessels develop scarring, intimal thickening, calcification, and stenosis of the coronary arteries. Later in life, scarring may continue, which would then increase the chances of myocardial infarction once again. Hypertension in children differs from adult hypertension in etiology and presentation. Children diagnosed with hypertension are often found to have some underlying disease, such as renal disease or COA. Systemic hypertension in children is defined as systolic and diastolic blood pressure levels greater than the 95th percentile for age and sex on at least 3 occasions. Childhood obesity is considered an epidemic not only in the United States, but also in other countries, with 38.8% of children aged 2 to 19 years old being overweight or obese, and 16.9% being obese.